We have exciting news. Our book, Hope for the Best, Plan for the Rest 7 Keys for Navigating a Life Changing Diagnosis, is available now for pre orders from all major retailers. And we have a special offer. Once you pre order, share your proof of purchase with us and receive a copy of our first chapter. Visit our website, waitingroomrevolution.com, for retailer links and all the details.
We're so risk averse as well that
Mhm.
sometimes putting your foot in it can be a source of humor that means you're human,
Mhm.
and then you connect even more, because if
Mhm.
you've got a good sense of humor, you can actually turn that around.
That was Dr. Leeroy Williams, a palliative care physician from Australia based in Melbourne. We talk about how people are cared for in Oz, what's the same and what's different, and how anyone can turn a consultation into a conversation. Hi, I'm Xian Xiao.
And I'm Sammy Winemaker. We talk to people who have information and tips on how to unlock a better illness experience.
The waiting room revolution starts right now. Leeroy, welcome to the podcast.
Thank you. Thanks for having me.
So, Leeroy, you're a palliative care doctor in Australia, and we'd love to hear a little bit of how palliative care is delivered in Australia and how that might be different than Canada.
Well, I know a little bit about the Canadian system, but not a huge amount. But certainly in Australia, I use the comparison of New Zealand and UK. So I trained in the UK, moved to New Zealand, and I was there for 4 years, and then made the move to Melbourne. And I have seen some differences there. So I think in Australia, obviously the funding system is very different from the UK, where it was the National Health Service and a free system. Obviously, I work in the public system, but many PAL care clinicians work in the private as well. So there's that kind of difference. Certainly over here, I know in America, and I'm not sure if it's the same in Canada, so that the kind of hospice is usually for people who are dying, and it's 6 months prognosis, that kind of funding model. Here we tend to have hospices that are mainly with pediatric palliative care, and there might be some services that are called hospices, but most of them are called palliative care units, and they're within a hospital sort of organization, so they're not standalone. That makes a big difference in terms of what you can and can't do, and funding as well. So in New Zealand, for example, many of the hospices are non-governmental organizations, so they're charity-based, and they often have to fund for services themselves. And they usually have a community arm to them as well. So they're an inpatient unit and a community service. Whereas here, so my service that I work in is an inpatient unit and a consult service, and there's a separate community service, which is, again, non-governmental funded, but it obviously doesn't have beds in the way that it would a hospice would in the UK or in New Zealand. So that's a kind of overview which I've found.
Okay, so who's doing it the best between New Zealand, the UK, and Australia? How would you rank them in terms of providing palliative care?
I think we've got those charts of the lists that have been produced. I think we're all trying to do our best in a broken system. Where the healthcare system, we all recognize, especially through COVID, has been broken for a long time, and we're just trying to do the best we can. And I think listening to some of the podcasts that you guys have done and trying to get this message of hospice and palliative care more upstream, I've always had the approach of holistic care. So we all went to med school, we all went to undergraduate, curricula for whatever discipline we trained in, and we were told about holistic care. We were told about this is good care, and then you enter the system and you don't see it. And I always thought I was a very holistic doctor in terms of when I was a junior doctor. And it was only when I came across palliative care, a palliative care nurse kind of highlighted to me something about a patient that I was looking after, that I started to realize I'm not as holistic as I think I am. So that's kind of set me down the path of of palliative care. But I think that if we were to incorporate holistic care throughout the whole of healthcare, because who doesn't need to be treated holistically, right? And I was at a meeting the other day, and I talked about what palliative care was, and they said, "Oh, what a pity we have to wait until we're dying until we get that." I said, "No, no, everyone deserves that." Yeah. So I think we're all trying to do our best.
Yeah. Yeah, that's the answer for sure. A question. So is palliative care taught in the curriculum of med students in Australia? Is it a mandatory part of their training?
There is a bit of teaching that goes on, so it can vary. It can vary from one day in the whole of the 5-6 years.
Yeah.
Or it can be or it can be 2 weeks. So I think within Australia, I've heard, 2 weeks is probably the maximum. I think internationally, the average is probably a week.
So, I mean, it's a piddlance. It's a spit in the fire, whatever metaphor we want to use. It's not enough for people to graduate medical school and understand that it's their business. It's not just a specialty, right? It's like you said, you can use whatever euphemism you want: holistic care, patient-centered care, needs-driven care, good medicine, human-centered, truthful, realistic, whatever, I mean, we could call it whatever it is, but it doesn't get enough real estate in curriculum for sure.
Yeah.
Okay.
And it's difficult to get that real estate, everyone's specialty is having new things sort of coming up, but that kind of art of medicine, and that's kind of where we're coming from a lot of the time, is because by the time we see people, they've gone through lots of treatments, and we're getting back to that whole thing of the art of looking after a whole person in conjunction with what we know with the medicine, but also from your more humane perspective, I think.
Yeah, completely. Oh, we've already got right hot out of the gate right now.
Yeah.
You know what? You want to know where I first learned of Leeroy, Cian?
Yeah,
it was through social media. Twitter actually is where we connected, Leeroy. I just found that we had similar tweets, similar things to say about palliative care and the system. And so I think we found ourselves as sort of kindred spirits. That's what I would say.
Yeah, look, Sammy, I love those tweets that you put out, where you've obviously gone into someone's home and you've captured the essence of that visit. I mean, the home visit is such a special thing. You're entering into someone else's home, just like we're entering into someone else's lives when we see them as clinicians, right? And it's the little things that you spot, and it's how you summarize them in those tweets that really hit home. And I think they really bring the essence of that person and what matters to them.
So, Leeroy, you were the past president of the Australian and New Zealand Society of Palliative Medicine. What did that role entail?
Well, that role was being the president of the Specialist Society between Australia and New Zealand. And it was a difficult role because we had COVID that happened. We had some fires in Australia before that. The whole assisted dying bills in Australia and New Zealand came up, and different states in Australia have got different legislation. In New Zealand, it's the whole country that they've had their assisted dying legislation. So there was a lot to deal with in that presidency. COVID took a huge chunk, and we tried to produce some guidelines looking at what our colleagues in the UK had done, because they had obviously had some of the first cases coming to them, and obviously the states as well. So we kind of looked at what everyone else is doing and tried to prepare everyone over here as best we could. That was not only on an organizational level, but it was also on a state level, and also from an international New Zealand and Australia perspective.
But you brought this up, and it was something that I wanted to ask you about, because in Canada, not recently, in 2016, we had the medical assistance in dying legislation, but in Australia, you call it VAD, voluntary assisted death, I think. was recently passed in some places and in New Zealand as well. So how has that impacted your work? I mean, it's been very controversial, I think, on some level, at least among the palliative care field here in Canada. I think that's fair to say.
Yeah, look, we had it in Victoria first, as the first state. And yeah, voluntary assisted dying is what it's called here. And I think, you know, my perspective is it has disrupted our work. So certainly what we're trying to do with patients and to manage their symptoms at the end of life, I think many people, because they haven't understood the legislation, a lot of the public are asking for it far too late. So they don't realize they have to be of sound mind to have that discussion and get all the paperwork sorted out that they need to. So that's one issue. There probably aren't enough doctors who put their hand up to do it. And that's another, you know, thing that we can think about in terms of why that's the case. And then there's also kind of, while you're trying to manage someone's symptoms, they don't want any drugs that's going to make them maybe not have capacity to ask for voluntary assisted dying. So they are holding off pain medications. They are holding off anxiolytics that might actually help them to be a bit calmer in their distress. So it has had an effect on how we do palliative care. And we're still in the process of working that out. I think in all the states are going to be reviewing that. And certainly I've had a lot of people come and ask me how we've managed it and the things that they need to look out for, because we were the first state involved.
You don't have to answer this, but are you have you been involved in either doing assessments or provisions of voluntary assisted dying?
No, I haven't, because I mean, I think from my perspective, I think the medical profession has had obviously a line on this for a long time. And my perspective, like I said, is about holistic care. And I want to see that everyone has that opportunity to get holistic care or the care that they need before we make that decision, or before they, you know, go down that line. People need to be fully informed. And at the moment, we already know there's these conversations are not happening. The access to palliative care is not happening. And so therefore people are making decisions when potentially they could have help. And so, like anyone who has suicidal ideation in any time of life, we need to be providing that support for them. We know how important mental health is. We saw that during COVID. You didn't have to have an illness to feel depressed or feel maybe that your life wasn't worth living. And, you know, if the legislation allows for those people to end their lives before they've actually had the help that they potentially could have, then that's a disservice, I think, to them. So I've kind of wanted to make sure that we can provide good holistic care and good palliative care and good support for people, like I said, in a broken system. And I think that the other thing is, as you've seen in Canada, how do you compare one suffering to another? How, you know, there could be someone who's working 3 jobs with 4 children at home, living in a really poor area. You know, they will be suffering. They may not have any illness whatsoever, but they will be suffering. There'll be a suffering of some sort. And so how do you deal with their suffering? And we've also had cases where people have been refused, not been eligible. And so therefore they haven't been able to go down the line. And then they're sort of left. And if we're there, then we can help to support them. But if we're not involved, that becomes a problem, because they do feel that they've been cheated. So there's many issues around this, very contentious, but that's my personal view. And I haven't been involved in any of them. I have been involved in cases where we've been providing the palliative care alongside, because we thought that was important to continue to provide that, but that the other side would be done by other people.
Yeah, so I guess the bigger question is, how do we get holistic care to people who are facing progressive life-limiting illness as early as possible in their illness journey, so that they don't roll down the hill and, land at the bottom and need, voluntary assisted dying because no one bothered to stop the rolling and, provide help. We receive people is so broken, don't we? Usually.
Yeah. I think that there's so many times where it's down to good luck who you would see as a clinician to get that kind of care that you should be having anyway. And this is why this, what you guys are trying to do is hugely important, because we need people to say, actually, no, I need to be treated as a whole person. I need to be having my questions answered. We need this shared decision making. That is the term that's used, but if you actually look at it, how you teach shared decision making is not really known. I mean, we talk about this term, but we haven't really incorporated it into teaching clinicians. And really, it's just listening and being curious and understanding that person's journey, their life, and how this illness is affecting their life and how their decisions might change accordingly. So everyone, like you say, everyone should be doing this when they see patient. And I think the other thing is patience. We use the word patience, but we're all patients, so we're all going to be patients. And so it means that we do have to think about having the conversations in the right way and as early as possible.
It's not fair to only receive holistic care if you just happen to stumble upon a palliative care specialty team at the very end of an illness. It's too little too late. Like, we're behind the 8 ball. We're working against the ticking clock, at that point. Okay.
Do you think you're getting there in Canada? Do you think you're changing that landscape?
I think there's a lot of effort. And I believe that there's a lot of really passionate people who are trying very hard to move that dial. But as I've said before, unless we embed this as a mandatory skill set in the curriculum of all healthcare providers, we're always going to be chasing our tail. It'll always be considered a specialty. It will always be positioned at end of life, and we'll never capture all the people that really require this kind of care. And so I still believe there are millions of people headed down the pipeline with, care that isn't holistic. It's focused on reducing them to an illness or an organ or a bed or a number until they land in our laps and we stitch them back together. So I don't think it's changing, but I think there's a lot of people trying hard.
But I think that's why, we have spent so many years under this idea of the waiting room revolution, because I think our belief after all this time is we will see the biggest change and the fastest change if we can activate patients, families, the public to come to the system with new questions, with a new insight into how to get this information. We've said before, we can't change the experience, we can't change the illness, but we can change the experience. And so, so much attention has been on training healthcare providers on how to have good conversations or communication skills or provide good medicine, but the public, the patients themselves are still in the dark. So I think we're trying to work on this other side with simple questions that aren't, framed in a palliative care, toolkit, but rather in a, what people wish they'd known sooner. And how do I get the most information? How can I be hopeful and prepared all throughout as early as they can for, the person with the illness and their family? So I guess I'm just curious, because you've, been following us for a while, like, what are your thoughts about this idea of the revolution, the podcast, the skills, the 7 keys that we're really trying to promote?
Look, I think it's a much needed approach. I mean, look, if you're not making the changes within the healthcare system, you've got to go to the public and make them understand what they're entitled to, what questions they should be asking when they come in, realizing that not all clinicians are the same, and that it's important to get their their story across, that they understand, that we as clinicians understand their lives.
What we're trying to do is help people get the holistic care at the very beginning of their illness and throughout their illness, so that they'll naturally get a palliative approach, but they don't have to ask for it. Because as soon as they ask for it, people will say, oh, you don't have to go there yet, or, oh, you'll get that at the end. Oh, you don't need that yet. We're going to try second, third line chemo. So it's not as easy as people asking for palliative care. They almost have to, again, ask in ways that they get what they need without, using the P word, which, we all talk so much about. Should we call it palliative? Should we not call it? Should we call it something else? But anyway, that's what we're trying to do, is leach out of the system what the patients and families need without labeling it.
Yeah. And I think also bringing the different perspectives of your guests that you've had on, just gives you a little bit of an understanding of what other people are doing and how they're trying to approach the same problem, and the successes that they've had, and sort of where they may have done things differently. I think those are really important learnings for us all to sort of, again, move things forward, move the dial forward.
Okay. Is the dial moving in Australia?
Look, I think there is a little bit of movement, because we're getting a lot of trainees who are doing dual training. And of course, when they do the dual training, they can bring that back to their own specialty, or to the other half of their specialty. So as dual trainees, they can be specialists in palliative care or geriatrics or, general medicine. But we're also getting some people where they would do 6 months of a clinical diploma in palliative medicine. So that's another option, where we can introduce them to what palliative medicine is like from a specialty perspective. So they come into an accredited position, and then they have that as part of their training for their specialty, and then they can obviously bring that into that specialty. So I think that's been a really good way from an educational perspective, that we've given people an opportunity to see good holistic care, good palliative care, and then be able to say, okay, right, now I've got that comparison. Oh, I can see where the gaps are. And then start to make some changes within their own specialty. So I think there is a little bit of hope there, that, that the junior doctors coming through are getting a little bit more of an understanding of what palliative care is about. I would hope so. That's my sense.
Yeah, we're starting to do that now as well. Train what we call Royal College. It would be similar to your dual training, and that's the idea, is that these people will go back to their specialty and enlighten them about infusing a palliative approach within their own specialty. I guess some people worry, though, that the same thing will happen to them that happened in family medicine, where we trained a bunch of specialists in palliative care, and it excused all of our colleagues in family medicine from thinking they had to do it. So the worry is that someone who's trained in cardiology and palliative care will set up a palliative care service, and then all the cardiologists think they just have to refer to that new palliative care trained person, as opposed to integrating the skills. So we'll see, right? Let's cross our fingers and hope that it works.
I think that whole specialist generalist kind of thing is still a problem, I think. And I think like on Twitter, I've said, you wouldn't expect a cardiologist to deal with all heart problems. So from a palliative care perspective, we are supposed to deal with the most complex cases of end of life or symptom management while people are having treatment that there is, but there should be something that people are doing before then that sort of is doing their bit. And the problem that we have is, because the education is so poor or lacking, when people enter the workplace, they need our support from a specialist perspective to try and do good care. And so we're stretched doing the most complex, as well as dealing with everyone else that needs that support. And hopefully we can get more people learning and say, okay, I got this now. I'll call you when I need you. And that's the kind of model that we've been running for a long time now, decades, because of that gap that we are having to bridge, that no other specialty is having to bridge. You don't see that in cardiology or gastroenterology or respiratory.
No. And so we will never get ahead until it's embedded in the curriculum. And, you know, so we can train all the palliative care doctors we want. We're chasing our tails unless we get to the underlying problem, the curriculum. But what are you most proud of in your career to date? How many years have you been working
in my career?
As a palliative care doctor?
I think what makes me very proud is when people have come up to me and said, I heard you speak here, or I remember this lecture, or I remember that encounter with a patient. And it's had an effect on them. They've maybe changed the way they practice, or they've come into palliative medicine. But getting those little bits of feedback, because we all do our job, and we just don't know the ripple effects that we sometimes have. And I think when people come up to you, and it's also patients and families, when they come up to you and say, you know, what you said then or what you did then really made a big difference. I kind of feel proud that what I've done has led to that point, but also it's had a good effect that I wanted to have. You know, we can always kid ourselves that we're doing good things, but you really get to see that when people come back to you, and it could be years down the line, they come and say that. So that makes me very proud of that. And also, you know, when people in the team go on and do great things, and you've been there in the background supporting them and enabling them, to giving them the confidence to go and do those things. Those are proud moments. And it's a little bit like, you know, with your family, with your kids.
Yeah, I love that answer.
Leeroy, was I wrong? Because last time we spoke, maybe on social media, you were thinking of doing a podcast yourself. Am I not wrong that it's already launched? And how's that going? What's the title? And tell us about it.
Yeah, so thank you guys for the help in trying to get some ideas around that. So we've called it Narratives of Connection.
Oh, it's beautiful.
Obviously, the idea being that we all learn from stories, and we learn from the stories from our patients, as well as the stories from, you know, clinicians as well. So it's launched, and we've had 2 guests on so far. I did another interview with a Canadian doctor who's actually working over here, but he's a very good friend of mine. So we've kind of done that. I'd love to get some stories of patients and families as well. And so I've got a few people who I've asked, and they've agreed that they would come on. So, you know, it's good to hear anyone's story and how that story has changed them or affected them. And so the kind of structure that we have is an idea of what's the story that's got you to where you are? What's the story that you're working on now that you feel is important? And then what's the story that you want to leave for the audience to think about into the future? So that's the kind of rough structure, but it's a kind of, we go where the conversation takes us, and
yes,
it's enjoyable.
I look forward to listening for sure. Yeah, where can we find it?
We've got a YouTube channel, so Narratives of Connections there, but it's also on the podcast for iTunes, not iTunes, what is it? Apple Podcasts, and Spotify. So we've got a kind of link tree thing where it goes to wherever. And actually, I mean, you mentioned that the social media was how we connected, Sammy, but and I think I may have mentioned this. My kind of intro into social media happened because we were teaching medical students in our university. It was one day of teaching at the time, and my colleague Michael Franco, who's an oncologist and palliative care physician, we were lecturing, and we both kind of thought, this is not enough. One day is not enough. We need to be available, and we need to be giving content to people beyond this one day of lecture. And so we set up a Facebook page, and that's Palliative Medicine Teaching. And we tried to put content up there, and then we kind of thought, well, why should it just be medical students? Why shouldn't we try and get everyone more up to speed with what palliative care is about? So we opened it up. We, made it. There's no kind of membership or anything. So anyone can log on, and they can be patient, family, clinician, and so that's grown over the years, and we've kind of put content up there, communication skills, anything about kind of, I really try to base it around holistic care as well. So that's been a way of us connecting with many people and trying to do exactly what you're trying to do, educate the public about what palliative care is.
And aren't you the brilliant mind behind PalMed-Ed?
Yeah, that's so PalMed-Ed is the Twitter
The
handle
Instagram.
of, and Instagram, yes. So we did an Instagram and a Twitter page in relation to the palliative medicine teaching page. So we had to, I mean, we called it palliative medicine teaching because it was medical students at the time. But when we thought more broadly, we couldn't change the name. We're already too far down the line. So PalMed-Ed became the hashtag or the handle for Twitter, and then we did the Instagram later on.
How long have you been doing it for, the social media?
Long time. I want to say 2012, maybe something like that.
Oh,
the Facebook page.
Really? Wow, you were what are they called? When
early adopters.
Early adopter. Yeah.
Well, we thought it was a really good way to connect with the students, but also to just get the message out, because there was no one. We had so many families coming in not knowing what palliative care was, or you know, mixing it up with assisted dying when the legislation didn't even exist. So we just wanted to make sure people realized, you know, what it was about and how we looked at people, and just promote that idea that we're trying to look at people holistically. Isn't that the kind of care you'd want? And if you're not getting it, then you should ask. You should go to, when you go to see your clinicians, ask to either see the palliative care team if you're in that point in time, or you know, why are you not asking me about my life in general, to understand a little bit more about me? It's a perfectly valid kind of question to ask clinicians.
So I wanted to ask this question about race and ethnicity in healthcare access, which relates a bit to some of what you post on your social media. So from an Australian perspective, and being a person of color yourself, how does race, ethnicity fit into palliative care access in your country? And do you still have the same type of disparities across the country as we read about here in North America?
So I think we do have some evidence that the people who get better access to palliative care are usually Caucasian, wealthy, knowledgeable, you know, and there's a number of reasons that we could sort of propose around that. But I think we want to make sure that we've got equitable access for everyone to get the kind of care they want or they need. So whatever the situation they're in, we need to make sure that it's readily available for that person to get it in a timely fashion. So I think that there are also, I mean, there's also the barriers of referral. So there's not only access and the availability, but there's also referral. Many a time I've heard the story from the patient or the family saying that we were told you weren't ready for hospice, or you weren't ready for palliative care yet. Or no, I don't think you should be thinking about that now. And so there's a barrier there in the referrer. So we need to take it away from being so dependent on the referrer to refer. We need to make it something that's much more objective, to say, this is what's needed right now. And that's part of, you know, what you're saying, something about integrating what we're doing. I think the best models have been when you've been integrated into, let's say, within the oncology team. So that integration of, we're all kind of working against cancer, and we're also here to try and support you as best as possible through this illness. And so that's lovely dog in the background. And pet therapy, you know, another element of what we do. So as part of the integrated team, we can provide more benefits, I think. So that's a problem. I mean, we have to advocate for people who are not getting access, and also people on the fringes of society. We need to actually advocate for their access to services where they're at the most vulnerable.
You know, that's so right. I mean, really, it's about person-centered care for everyone. including the most vulnerable, all the time. So that's what we're really trying to do with this podcast. And as you know, our podcast has become a book, and that book is sort of a how-to guide for patients and families to understand how to leach out a palliative care approach from the system without the labels. So I'm curious to know your thoughts as to whether you think this a how-to guide is even needed, and do you think that it'll work?
Look, see, and I think that's a great idea, because giving people the opportunity to have some signposts that they are doing the right things, or and once they see something that they haven't thought about modeled, they can then go away and use that and see what success they get. The problem we have with communication skills, I think, is, well, first of all, people have some innate communication skills, they just don't realize it, right? You know, when you're having a drink with a friend, you don't kind of think, okay, is this the right environment? Am I nodding enough? You know, it's natural. And when your friend tells you something that is hurting them, you have a natural way of dealing with that. I think so. The professional box that we have to work within puts the pressure on, because, of course, within medicine over many years, people have been told you're not supposed to be emotional. And of course, things move you. You will see one movie, and the reason why that's your favorite movie is because it moves you in some way. The other movies don't move you, and so therefore you don't remember them. And it's the same with patients. And if that's a natural human emotion that comes out, then that's useful to connect. So that's part of the problem. So there's that element of people thinking it has to be in a professional box, and then they fear that they're going to do the wrong thing or say the wrong thing. There's also the element of, once you're going from a script, that many patients and families recognize it, you know? So once they do the kind of lines that they've heard, because they need a structure. When you're starting, you need a structure to sort of hang things on. But the problem with the structure is it becomes recognizable, and then people start to sort of think, well, you're not being authentic. So I've always tried to approach it from an angle of being curious about the person and who they are, and trying to keep it as human as possible. When I was a registrar in palliative medicine in Auckland, I would know that someone was coming across, so I'd look at their notes, and then I would leave any paperwork that I would go and have a conversation with the family and the patient, and I would just say, tell me your story. Because I know that I've been given some information, but you tell me your story. And we'd have a conversation, and then it would go wherever. And I'd get a sense of who they were, the relationships with the family members that were there. I'd get a sense of how they were stoical or not, stubborn or not. And then I'd say, right, thanks very much. I'm going to go and write this up. And then I'd write my notes, and I'd go, give me all your medications, take that, chart them all, come back. That would mean if I had any questions, I could come back with the bag of medications and say, here's just add some other things I wanted to ask you. And then it's turned that whole consultation into a conversation.
I feel like I need to tweet out right away, turning consultation into conversation. That is awesome. But I think you're so right that, like, we can, as humans, have natural conversations all over the place, and we don't need a tool. We don't need a workshop. We don't need a structured algorithm or set the environment up. So why are, like you said, why are we so stiff when it comes to, you know, just sitting with other humans and talking about how they're doing, or, you know, and you're right. It's, people are scared that they're going to put their foot in their mouth, so that they're going to say the wrong thing. And you're right, with all the tools out there, they're not flexible and nimble. So they're recognizable, but also they don't allow you to respond to the way the patient or family responds to the question. So
there is the ALOBA model. I don't know if you've heard of that, which is a gender-led outcome-based approach. So you go into a consultation, and our agenda might be to just make sure the pain's better, and we're going to have a plan for discharge, and that the person agrees with the plan for discharge. So before we go in, we say, okay, this is our agenda. How are we going to know that it's worked? And then we'll say, okay, well, the patient will say, my pain's better. And yes, I'm keen to go home tomorrow. So one member of the team is going to look out for those kind of flags at the end to say we've met the outcome. And then another person is going to look at the whole comm skills approach. And we go in and we have the consultation. You often get in there and the patient's got a very different agenda. Now, if you try and stay with your agenda, it's going to go nowhere.
Yeah.
So you have to then think, okay, well, you've got a different agenda. Okay, tell me about what's going on for you. Oh, right. Well, you can't go forward until you deal with that. So that's a really flexible model, and that kind of works very well because you can come back out of the room and then you say to the team, what do you think happened there? And then they can say, well, they had a different agenda and we had to go and whatever. The other thing about it is that also when you go into that approach, the emotions. So you can't deal with anything until you deal with the emotions. So we have to be good at dealing with emotions. So that's another problem because obviously clinicians are not taught about dealing with emotions, right? So that's why the comm skills often is good to sort of focus on that. That when we do get the comm skills teaching, sometimes that really does come to the fore, and people then go, oh, okay, fine. Now I know how to deal with that, or now I've got to work out a way to deal with that. But the other thing about, we're so risk averse as well that sometimes putting your foot in it can be a source of humor that means you're human, and then you connect even more because if you've got a good sense of humor, you can actually turn that around.
This is why I love working in people's homes, because you aren't surrounded by the sterile environment of the hospital or the clinic, right? And you are communicating with the patient and the family becomes your care team, right? So you can only communicate in the most standard, human, normal, approachable kind of way. When I have people come with me, they often say, oh, I've never heard someone talk like that. I'm like, we all talk like this. We just don't usually do it in these scenarios. But like, why should I communicate any differently when I'm sitting in front of a patient and family than I do, going grocery shopping? Like, I'm only human and they're only human. And it does them no good for me to come in on my high horse with my fancy words and, cryptic kind of approach to, not really talking about what's right in front of us. Like it's the home environment, which is also a missing piece of the curriculum, training people in the home environment really does bring you down a few notches as a physician, to be honest. And it's a good thing. It balances the power differential that we grow over people's training. It fills that gap a bit. But I love what you're saying about communication. I just love it.
We're so glad to have learned more about your work on today's show. So keep doing what you're doing.
Yeah, more power to you. Keep doing what you're doing. And I think we need more people to advocate for people to get the right care in the right way at the right time.
Yeah. And more power to you too. Seriously. I love what I'm hearing. I feel like your philosophy is very aligned with our waiting room revolution. You can join our revolution. No problem. Honorary member.
Thanks for listening. Don't forget to rate, review, and subscribe if you haven't already. You can visit our website, waitingroomrevolution.com, to learn more about our movement and how you can join it. The podcast is produced by myself, Kayla McMillan, Valerie Bishop, Shilpa Jyothi Kumar, and Maggie Sivak. Our theme music is Maypole by Ketsa.